Good morning, Susan. And I hope, Robert, you're there somewhere. It's great to see you and be with everybody. And so I'm just going to activate my share screen once I'm allowed to. I think you might have to stop sharing yours first, Susan, before I'm able to. For all those who have joined us for the SADS Foundation virtual conference, welcome. I see the numbers coming on in. And it's great that you chose to spend your Saturday with us and part of tomorrow as well. And let's see if we have mission accomplished here. So I'll look on my slide, and if I can get a shout out or an amen that everybody can see. And
looks great, Mike.
Great, thanks, Susan. So who says that I can't play anyway? In this lecture, I'm truly honored to give it. It's our first of what will be many honorary lectures to honor Dr. Robert Campbell, and I am delighted to be the first. At least since I'm starting it, it will be the best Dr. Robert Campbell honorary lecture ever to date. I would love it if it stays that way, but I hope actually that we will have amazing ones to follow. They deserve to be amazing lectures because Dr. Campbell is truly an amazing man. So I can't wait to hopefully see you on screen, sir. But until then, over our next 35 minutes of my monologue and then 5 minutes of a dialogue as I'm instructed by Marcia, and shout out to Marcia and Aaron and Anna and everybody at the SADS Foundation. On behalf of our CEO, Alice, thanks so much for joining us. I'm conflicted. These are those conflicts of interest to disclose. I don't think they're going to affect our ability to communicate these things well together, which is, I hope that we can assess both the past and the present expert opinion guidelines that have shaped our conversation that we as healthcare providers have with many of you, patients and families, when it comes to competitive sports participation, given the diagnosis of your condition, and then really examine the data that has been compelling, I would say slowly, but certainly and steadily an evolving shift from a de facto disqualification, sorry, Johnny, you're done, sorry, Sally, you're done, to shared decision-making. And I often, when I speak with the healthcare provider community, will start this topic with a question to them. And you could ponder it yourself, whether you're a healthcare provider joining us today or a family with one of these conditions, because you face this question: would you allow an athlete with a sudden cardiac death, SCD, predisposing GHD, genetic heart disease, in other words, a SADS condition, and prior on the field syncope while undiagnosed and untreated, to return to his or her sport of choice? And it's incredible over the years of posing this question to see a slow shift from a vast majority, no, they're done. The majority is still a no, but there is a silent and a growing minority of yes, and even more encouragingly, a swelling group of maybe, which means if you're a maybe, I may be able to have an opportunity to swing you from a no to a yes. But for those who've been a no for the last quarter of a century, they've been in good company. They, in fact, have been practicing guideline-directed medicine, because from the guidelines, the no's have had it dating back to 1994, now almost approaching 30 years, where then it was simple. No, you're done. Unless your heart is perfect, no competitive sports, period. We updated that, and this was the first guidelines that I participated in now some 15 plus years ago. And there we said, unless your heart is perfect or the syndrome is confined to just your genome, no competitive sports except perhaps class 1A sports. So whatever disease is represented here today among the participants, it didn't matter. Whatever your channelopathy was, your cardiomyopathy was, you were advised by guidelines, no competitive sports. So any physician permitting you to play in 2005 was practicing contrary to the so-called expert opinion guidelines. Long QT syndrome, it was a no. And I think it's really important to look at what nuances we established back then, because there was a movement even then ushered in with some wiggle room. We said that you would be disqualified if you had long QT, if you were symptomatic. So anybody with a long QT triggered event, you're done, or never a symptom, but your QTC's at rest for men and women crossed a certain threshold. But here's the important break. It may not seem like much, but this was actually quite significant, because we added this. We said that those who had a positive genetic test, you've heard them referred to as genotype positive, but were phenotype negative, meaning for long QT, their ECG showed a normal QT interval at rest. For hypertrophic cardiomyopathy, the echo was normal. For CPVT, the exercise stress test was normal, phenotype negative, that we felt that we ought to give an okay to play. And we made a little exception there with this swimming LQT1 thing. So symptomatic long QT, you're done by guidelines. Never a symptom, but I don't like your QTC, you're done. But those who had a positive genetic test only, we could support a return to play. And then that brings us up, but we had that little carve out, remember, of maybe we could keep even the symptomatics or the asymptomatics, but prolonged in 1A sports. For many of you don't have any idea what 1A sports are. And so you're saying, please tell me that there's something good in there for my son and daughter. There's not. So here was Task Force 8, and you can see what sport you do or your family has been doing and see if it falls in 1A. So 1A is the bottom left-hand corner with the lowest dynamicity, the lowest static component, and deemed to be the safe 6 from an okay to play standpoint. So forget about any other sport, every other sport. We would, by guidelines, support billiards, bowling, cricket, curling, golf, and riflery. And a late breaking up news update, billiards has now been declared no longer part of the safe 6. It's been deemed too dangerous and has been replaced by yoga. So to stay within guidelines, we were stuck as the healthcare providers with these 6 activities. Now, it was quite interesting on the other side of the pond, across in our friends from Europe, they went retro in 2005 back to the American 1994 guidelines, because they said, unless your heart is perfect, no means no. Don't even give you cricket. And so here, if you look specifically for long QT syndrome, they advise disqualification for all competitive sports, symptomatic, asymptomatic, doesn't matter. And then check out their very stringent QTC cutoffs that would define you as eligible for disqualification. Now, quite different from what we did in North America, they did not give an okay to play based upon solely a positive genetic test. So this was quite intriguing that here we have for just one of the lesions, and this was true for every one of the cardiomyopathies and channelopathies. And long QT syndrome, we said that those with what we call concealed long QT, positive genetic test, but your ECG looks awfully normal, may be allowed to play in sports. Europe said, forget about it. Manifest or concealed in terms of your ECG, you are done. You gene carriers, you are done. This is quite sobering, isn't it, if you think about it? What they're saying is a positive genetic test alone, finding this, the X that marks the spot, is sufficient to disqualify you from everything. There better be really good evidence for it. So I'm going to show you the evidence for that statement. If you have a blacked out screen, don't worry about your connection. This is the level of evidence. There is none. So I've called them out on this for a long time now, for 16 years, and call it what it is. We need at times to have unabashed clarity. And I think I might have learned that from Dr. Campbell, to call it as it is. And I called it what it was and is: genetic discrimination. And here we, in our guidelines, we were very transparent in the strength, the underpinnings of the guidelines. And reading back on it, putting this together, we were actually quite refreshingly transparent. We said that these guidelines, what we're recommending to you, the families, was based largely on individual and collective judgments and experiences, and that we were practicing the art of medicine. So I'd be curious, over your family's journeys, when you were disqualified from the activities that you loved, were you told that we, the healthcare provider, we were feeling and being rather artistic in our recommendations to you and for you? We said that this would occasionally cause some athletes to be withdrawn from competition unnecessarily. Too bad, so sad, because we deemed it a controllable risk factor. How do we control this risk factor? By refusing to be the ones to write that signature that would let Johnny, Sally play for their upcoming school season. We then self-proclaimed the wisdom of these conservative nature of these recommendations and justified our "if in doubt, kick them out" posture. And I did say I was a member of these guidelines. I was sort of the voice and the little hand as a very new, just 5 years on faculty at the time, saying, I don't get it. We have got to create wiggle room. So probably correct to say that I was the catalyst for the positive genetic test only being insufficient to disqualify somebody, whereas the European guidelines did not have that voice to declare that. What may also undergird, if you will, the very disqualification prone leaning, for which I would argue that this is still perhaps the majority position in cardiology. It's legal. The elephant in the room is the fear of a lawsuit. This dates back to the Knapp versus Northwestern University case, but even though, to my knowledge, there's still not a well-defined legal precedent for somebody in the healthcare provider community, getting sued because we let you, Johnny, Sally, play and then tragedy happened. I think that still remains the elephant in the room. So that has been the basis, I think, for persisting with "if in doubt, kick them out." But then check this out. The winds, with respect to guidelines, the winds started to blow in a different direction, because starting in 2013, led by Sylvia Priori and Arthur Wilde, who is one of my dearest friends who you're going to hear from today, they said in their guidelines, and this is a profound statement, really, a class 1, that means it's a must recommendation. All long QT patients who wish to engage in competitive sport should be referred to a clinical expert for evaluation of risk. That's profound, because why do you need an expert to be told no? So something started to happen from a guidelines perspective to open the door for the possibility of continuation in your sport of choice. And then it really happened. And now 10 years later from my first guideline, I had the privilege of chairing the guideline, at least this task force, no longer called the Bethesda, but called the American Heart Association and American College of Cardiology scientific statement, to which since 2015, the disqualification predisposition of "if in doubt, kick them out" has been lifted. Ah, that's called freedom, because now we, the healthcare provider community, we could potentially engage in a conversation with you, the families, without this backdrop of saying, if I let you, I'm going against guidelines. Now I could potentially be consistent with and compatible with the guidelines. And so I love what this has done for our healthcare provider community, because look what it says now from the guidelines for long QT syndrome. It says, just like Arthur Wilda said, see an expert. Not to be able to be told no, but so that we can do things like ensure the diagnosis is right, risk stratify well, treat well. We said that we need to have a mindset of a penalty box. In other words, we need to adopt a concussion type protocol. In other words, you can't have a feint of concern that gets you put in the penalty box on Friday and then expect to play ball on Monday. There needs to be a pause. That episode, that scenario needs to be delved into. And whether it's 3 months or 2 months and 1 week, the point was there needs to be a slowdown and a methodical, careful evaluation. We said back then, and it's still true, and it's been true since the day I said it 15 years ago, there is still no evidence to disqualify based solely on your DNA, solely on your genetic test result. And then look at what we even said for symptomatic long QT, for symptomatic long QT. We said even LQTS athletes with symptoms or the asymptomatics with long QT intervals may be able to return to play. So in other words, all of the disqualifications of 2005, all of them were rescinded to a very different mindset. And so look over now almost 30 years, 27 years, we've gone from if in doubt, kick them out of everything to unless your heart is perfect or the syndrome is confined to just your genome, no sports except 1A, to now the law of the land, if you will, the mandate. Oh, that's a hot word. After you have been well evaluated, well risk stratified, well treated, and well informed, a return to play may be possible. What is this called? Shared decision making. Just like we do in so many aspects of medicine, or at least we used to do in so many aspects of medicine, where we decide together what makes the most sense for you, for your family, and is it reasonable to do so? And quite excited about this work that we gave as on our mind as to how we view this whole issue should be conducted. You could say this is philosophy, because I rejected the if in doubt, kick them out philosophy when I joined Mayo staff in 2000, over 20 years ago now. My philosophy then and now has been respect patient and family autonomy and your right, their right to make a well-informed decision. We are seeing the guidelines start to embrace this philosophy, but they're not doing it because they agree with the philosophy. The guidelines are starting to do it because this perspective, this approach is now being buttressed by data. And we started and have provided much of this data. And let's examine the data that justifies the reasonableness of this approach. We felt that if we're going to be swimming upstream, that we better examine this really carefully. And so this was our first examination of our first decade's worth of patients who had come to see me at Mayo Clinic. And not all of them are athletes. So for sure, if they come to me as a non-athlete, I don't try to make them an athlete. I love sports, but not that much. But many of them were. And of those athletes, we very early on observed something really important that allowed us to debunk a myth. The myth has always been that if we, Dr. Etheridge, Dr. Campbell, the healthcare community, if we gave you the choice, the families a choice, they would always return to their sport. And we debunked that and said, that's not true. I actually think if you allow families to choose and weigh things in the balance, there will be times when the family unit decides, nope, not worth doing. And we observe that. In fact, we continue to observe that. About 1 out of every 6 athletic family who specifically flew to Mayo Clinic to try to return to play or to pursue that question. In other words, highly motivated. After all was said and done, they disqualified themselves. Now, the majority, then and still now, hear everything and they say, I understand. If it's possible, we want to proceed. For us, our family unit, that sport is more like what I call O oxygen rather than O optional. So these first 130 athletes who stayed athletes, this is what they look like. And you can see 15% have a defibrillator. So most of all of my athletes of any genetic flavor, long QT, CPVT, HCM, do not have an ICD when they continue in their sport of choice. And check this out, they just don't arrive to Mayo Clinic doing these sports. They're just not doing cricket. And so we let them stay doing what they are, who they are. And we don't try to get them one box closer to cricket, which, as an aside, has the cricketers really upset that their sport has been classified in the lowest risk category of sports with respect to dynamic and static component. They want out of the 1A category. They say they at least deserve to be put where table tennis is, please. Now, and then the other observation early on is look at that number 9D. If you understand long QT syndrome, we actually have a fair number of at-risk individuals called the 90 little league boys, where we know before puberty, long QT is more expressive. And then here, over half of all of our long QT athletes, over half, have that LQT1 flavor, for which we know that LQT causative faint, seizures, or worse are more likely to be triggered by adrenaline, aerobics, sports. And so what did we observe back then? Uno, 1 athlete, dose, 2 events in 650 plus athlete years. And were we surprised by that athlete having an event? Not really. Look, he's 11 years old, LQT1, wow, long QT interval, and even a prior out of hospital cardiac arrest, who was among that 15% with their own defibrillator. And in fact, he's had 2 VF terminating ICD shocks, one warming up to play soccer, the other during baseball. This 11-year-old is now 20-something, played collegiate soccer as goalie, and is now in an engineering career path. Now, speaking of the ICD, that story of the ICD kind of has advanced in parallel with the data being generated from my entire practice, because back then by guidelines, the presence of an ICD disqualified you all by itself. In fact, it was viewed as oil and water. And ICD and sports don't mix. Forget about it. But even back at that same time, another maverick, Dr. Rachel Lampert, a dear friend, who said, is that true? And she queried the Dr. Campbells of the world and the Dr. Etheridges and said, do you agree with what the guideline says? And found that half of practicing heart rhythm specialists didn't agree with that oil and water configuration. In fact, so much so that with that observation, Dr. Lampert started the ICD sports registry, which took a lot of heat, because you can imagine that was sort of blasphemy. That was an oxymoron. How could you have ICD and sports as a registry? There shouldn't be anybody there. Well, they are there. They were there. And she found them, about 400 such athletes with defibrillators that we've been following and publishing our observations together. And you can see with 3 years of follow-up initially, of course, there's going to be some shocks appropriately. They got a defibrillator for a reason. But importantly, you see the spectrum of lesions represented, the SADS conditions present. And the leading one was long QT syndrome, but a lot of hypertrophy, ARVC, and so forth. But one of the most important questions that was answered was, because the concern has been, it's too dangerous to the person to let them return to their sport. It's too dangerous to the box, to the device. Well, what's the data? The data was zero. There has been zero evidence that there's been excess mortality, danger to the person, and zero evidence of excess damage to the device. We extended the follow-up more recently, and still the same thing. So you can see in this group of patients, it's about a 3% number. Remember that, 3% among these patients, a 3% chance per year, or a 3 out of 100 person a year of getting a shock appropriately while being an athlete. Now, importantly, many of these were not even during their sport. It was just during things called life. And we then extended our follow-up 3 years ago, and there's an important observation here among our whole cohort. See what number we're at? About 1 per 100 athlete years. And again, these are all comers, 80% without a defibrillator, 20% with a defibrillator. But 3 years, this was an interesting nuance. Who would you guess has less events, the athletes or the former athletes? The athletes. My athletes actually have fewer events than the non-athletes or former athletes. Why? I think it has to do with the phenotype of an athlete. What is that phenotype? Discipline, driven, follow the drill, do not want to have an event. I'll do the treatment program. I suspect that's part of the why that this is sort of the opposite of what one might have anticipated. And then thanks to many of you out there, you have enabled Rachel and Charlene Day and myself to have this NIH-funded study, now fully enrolled, over 2,000 people from age 8 to 65 with long QT syndrome, and over 2,000 with hypertrophic cardiomyopathy, where we're now following and analyzing what has been the experience among all of these young people and less young people in terms of events compared to their activity level status, athletes and not athletes. And we will get an answer soon, probably in the next year, as to whether this hypothesis is correct, which was and is that those of you with either of these genetic heart conditions who are the most active in life will have a higher quality of life than those who have been the most sedentary, without having that result in more disease-triggered cardiac events. I can't wait to see what that answer is. In the meantime, here in the Windland Smith Rice Genetic Heart Rhythm Clinic at Mayo, we just updated this summer our entire 20+ year experience now from among the over 4,000 patients I've evaluated, published this summer, to see what is now the latest score. And here is the latest. I currently follow about 700 athletes with a variety of genetic heart diseases, mostly long QT syndrome. And you can see the number, about 6%, that have experienced a non-lethal cardiac event in a lot of athlete years of follow-up. And so here's the point number: 1.7 events per 100 athlete years, 1.7 non-lethal events. Remember, in our ICD registry, 3%. So that's a higher collective phenotypic risk group. All comers, 1.7 for these nearly 700 athletes. They're still just not doing golf, only 10 of them. And you can see how they're everywhere doing what they love to do. And we're starting to get event rates for the kind of sport you're doing. And you can see it's kind of all over the place. And so there really doesn't appear to be any trend, any evidence that the static and dynamic nature of your sport has anything to do with what your event rate is. We're starting to get lesion-specific event rates, again, led by the majority experience with the 500 with long QT syndrome steadily at 1%. We published this before in CPVT, and you can see we don't have very many athletes with ACM being athletes because we, like others, discourage that kind of coexistence, certainly with endurance training sports in arrhythmogenic cardiomyopathy. And it continues to be zero. Now, no deaths for 20 years. And I am soberingly reminded that when I gave a presentation in South Africa many years ago, an ethicist, a philosopher came up from South Africa afterwards, and she told me, and I'll never forget, she said, your approach is right. And so when you have your first death of your athlete, of one of your athletes, do not change your view. So that challenge has not occurred yet. It hasn't been tested yet because thankfully it has not happened yet, but I'm not under any delusions that there could be and may be a time in which one of my athletes doing what he or she wanted to return to do experiences the ultimate tragedy. I hope I'm wrong on that one. I hope that never happens, but the families know well that this is not a zero risk scenario. And so for those families and those healthcare providers who want to reject, if in doubt, kick them out, who want to embrace and be cared for under this model, then they, both sides of the aisle, the patients and the physicians, the healthcare providers, must operate under 6 critical caveats in place. And I think the first may be for the healthcare provider, are you the right person to be doing this? It's okay not to be. It's okay to refer them. It's not okay to disqualify them without much explanation and then leave the families in the dark, searching on their own, Googling a way to potentially find a different healthcare provider who may be operating under this, shall we say, enlightened approach. Second, the athlete and his or her parents must be in agreement. Those of you who are my athletes in our program, you know that one veto vote within the family unit disqualifies you. And so that verdict within the family unit doesn't happen at the end of the first 2-hour patient encounter. That must be dealt with and sorted through. 3, there can be no covert operations. Families, you know that I will not accept that we keep this hidden from the coaches, the school officials, the trainers. They must be informed so that a simple safety drill can be put in place. That simple safety drill includes you having your AED as part of your safety gear for sports, just like you would have your own EpiPen if you were an athlete with a peanut allergy, no exceptions. You need to be reminded that there really is no such thing as shared decision-making when it comes to the university or professional level of sport. This shared decision-making model will work quite easily throughout Little League, junior high, high school, Division II, Division III college sport, but not D1 and above. There it is what I call TDM, their decision-making, BDM, business decision-making model. And so that's important because just like the athlete with yesterday said, do not believe anything the coach who's recruiting you says, because it needs to be brought up the pole so that the team physician has given you the green light go, and so forth. And 6, for the healthcare provider community and for you as a family to understand, you have to document in the medical record things like this with this level of clarity. He or she could die suddenly. This is not a zero risk scenario. There is a tangible risk. It is low. It is 1% non-lethal event rate in my program. It is 3% ICD shock rate among the ICD positive athletes. Death in 20 years is 0, but that doesn't mean this is a zero risk proposition. You deserve to know that with that kind of clarity so you can weigh it in the balance. So as I wrap up my 30 minutes on the counter here, and I give you, say, 5 or 6 take-home points besides those 6 caveats, and then I think the team has put in place about 5 minutes for a conversation together. So I'll leave you with these. First, philosophy and art trump science and evidence as the underpinnings of the sports participation guidelines, although the evidence is mounting. Second, because of that, the athletes and you all have the right to know what's the evidence or the lack of evidence that has gone into your disqualification recommendation. Did you know, were you told that the healthcare provider was being artistic when they told you you're done with your sport? 3, the earlier guidelines were not only too strict, but they also, hopefully inadvertently, advocated genetic discrimination. Athletes and their families are fully capable to choose to disqualify themselves. So any healthcare provider who's on the call, just know that families can make these tough decisions. They won't always say yes. Sometimes when they weigh it in the balance, they will conclude as a family unit, it is not worth it. And when they disqualify themselves, they will get along in life way better than when we unilaterally pulled the rug out from under them. And 5th, among those who have chosen to remain a long QT athlete, and I would add a CPVT athlete and an HCM athlete, their disease event rate has remained a non-lethal one and an extremely low one. In fact, a lower event rate than my non-athletes. We should also ask ourselves and just acknowledge that I think it's really the fear of malpractice, the lawsuit, that's the elephant in the room, that historically has distinguished, you're done from competitive sports, but you can do whatever you want in the backyard. Never made any sense. We should also tell ourselves that this role of a disqualifier, it's actually kind of easy. That's 30 seconds, you're done. Whereas this role of informer, educator, and a co-participant in shared decision-making can and does take hours. And for the healthcare provider, you need to ask yourself, are you the right person to be doing this? Get them to the right person. If your intrinsic default wiring is, you're disqualified. I don't know why, but you're disqualified. Get them to the right person. Finally, I'm often asked, Mike, when are sports not worth the risk then? You seem to just say yes. I don't just say yes, but we can unpack that later. I would answer this question this way. Sports are not worth the risk when a well-informed athlete and his or her family concludes so, or the data, as in ARVC, for example, and endurance training sports, clearly compels such a conclusion. Well, this brings us to the end of the first Dr. Robert Campbell Honorary Lecture. Robert, if you've been listening, I hope I've done justice to the name of this lecture. Thank you for being that father figure to me. Thanks to the entities that support our program here at Mayo Clinic, especially the philanthropic support from Wendy's family. And I hope that together, as we've kicked off our virtual conference, that I've done my part to heal the sick, advance the science, and honor a very dear friend in Dr. Robert Campbell. Thanks, everyone. And I think, Marcia, I see your lips moving, but you're muted.
There you go. Thank you, Mike. Appreciate that. We have some questions coming in from our participants. So I'd like to read those to you. You've touched on some, but I'd like to just kind of go through them and you could address those. How would you suggest socializing long QT with school staff, like coaches, away teams, etc.?
And so how would you said socialize?
Suggest socializing long QT with the school staff.
Yeah, so I'm not sure what they mean by socializing. As if it's about informing them to have awareness, I think one of the best things you all can do is to make the coach, the nurses at the school system, the trainers, whoever needs to know, aware of your SADS condition, is to bring them to the SADS Foundation, point them out to the materials. For my own athletes, I actually have a quite an extensive paragraph specifically for the trainers, the school principal, just giving them sort of the basics of that student athlete's health issue. I try to demystify it, honestly. I try to tell the school nurses and the coach, do you have a kid on the team with a life-threatening peanut allergy? Oh, yeah, we do. Okay, I said, well, this is going to be easy. Do you have somebody on your team with diabetes and sort of the sugar drill if they have a reaction? Oh, yeah, we do. Easy. Do you have somebody with epilepsy? Oh, yeah, we do. So I try to take away the stigma that somehow our SADS conditions are spookier and untouchable, and to try to mainstream them, if you will, to the normal. And that if the school nurse and the school coach and the team physician at the university are comfortable with the peanut allergy kid on their team, then they have to be comfortable with a SADS condition person on their team.
Okay.
And I'll also invite during this question and answer, if Dr. Etheridge wants to jump on in at any time with her experience and comments as well, that'd be great fun.
Very good. I think she may even grab Robert.
Oh, maybe. Robert's like, he's all retired now. Everything I learned about this, Michael, I learned from you, from either hearing you speak or reading your papers. And I've actually gotten to write some editorials for these papers. And so I believe in it exactly like you do. I struggle a little bit with rhythmogenic cardiomyopathies. They're a little bit harder, but the rest of it, I think you have empowered me and so many in this community to just do it. Let them play.
Very good. So what sports would you think are safe for long QT type 1 and long QT type 2?
Yeah, easy, everyone, every sport. So I have, in fact, this is going to be viewed as heretical. I have 2 LQT1 swimmers where one, she thinks she's going to make the Summer Olympics in Paris in 2024. That's her goal. And then the other one, she's a little bit younger, so she's got eyes set on 2028. So she just gave me this one as she set a record in her high school state. So I don't know if you can see that. That's called the butterfly stroke. And so I guess the point is, yes, LQT1 and swimming is a twitchy combination when you are an undiagnosed and therefore untreated LQT1 person. When you're diagnosed and treated, we've neutralized the threat tremendously. And I'm actually far more comfortable with my LQT1 swimmer who's in a captured, confined space than my LQT1, LQT2 downhill ski people, where just the safety drill it's not quite as easy to implement. My 5K, 10K runners, where, okay, who's running with them? So when you're in a confined pool with an observer there, eyes on you, and the AED rescue plan, I'm really comfortable. And yeah, I mandate the AED rescue plan, but just for the participants to know, and I don't know if, Susan, you have an exception. I actually, to date, still do not have a single athlete where the AED has been required. So not one.
Me either. I have it. It's like the safety blanket. It's like the net under the the aerobic athlete. But I always say, if you're going to be a swimmer, your AED needs to have a really good towel with it.
Yeah. And you probably also tell them to use it after they get out of the water.
Yes. Yeah. Dry towel. Yes.
Okay.
I worry about it, but I do tell them swimming certainly is safer in the pool where we can see the bottom than in the lake or the river. And caution them a little bit about cold water and getting in slowly, et cetera, because I think that can be a problem. But yeah, I think letting them swim if that's their love. Luckily now, I think that we meet our long QT syndrome patients when they're very young, and we can somewhat direct their and have the family direct their athleticism. So I have a clinic in Alaska, and I worry about running in the trails in the backcountry alone. So that to me is a bigger scare.
Yeah.
Okay, here's another question for you, Mike. In order for athletes to return to sports, what dosage of beta blocker should they be on in order to return to the participation of sports?
Yeah, great question. And I can't answer that with a dose because it's not a one size fits all answer. They get a return to their sport of choice when I'm pleased, is the bottom line. And if I'm pleased with their treatment program and their level of protection that I've assessed on a dose of 40 of Nadolol, so be it. If it's 60, so be it. If it's 20 and denervation, so be it. If it's 0 beta blocker and denervation only, so be it. So it really isn't a certain milligram number that is the number that gets the ticket punched to be back on the squad.
I agree. The type of beta blocker, however, is very important. And I'm a big believer in Nadolol above any other. Propranolol is a second choice.
Yeah.
Okay, thank you. Here's a ARVCD question. My cardiology team initially recommended that I steer clear of all strenuous activity. I removed soccer and ultimate frisbee, but continued biking, hiking, yoga, and Bari, which I'm not sure what is. Now we have requalified that statement. Now, I guess now that we have requalified that statement, are recommending that I avoid all activities that the normal population would consider strenuous. Is it perceived strain or actual heartbeats, lifetime that matter? That's the question.
Yeah, that is such a great question. And I'll start by saying I'm totally unsatisfied with how we are treating our ARVC families with respect to our sports participation, staying heart healthy recommendations. There are programs, so Johns Hopkins program, probably one of the largest ARVC centers in world. For a long time, they've more or less had a 0 dose sport recommendation, that there is, in other words, no such thing as a safe dose of activity. And maybe it's because that's the same thing that our long QT athletes were told some 20 years ago, that there was no safe dose, you have to be disqualified from everything. HCM patients were told the same thing, that I don't think the 0 dose sport recommendation makes sense. I've seen just an unacceptable number of train wrecks psychologically who didn't get along very well at all in life after they were disqualified, who not only became sedentary and overweight and bring about all kinds of health issues that existence does, but I mean mentally, emotionally not healthy, not good. So we have to figure out a way to get our ARVC athletes. Now, in contrast to the long QT athletes where I told you that I don't tailor them, Marcia, I don't try to get them one less dynamic box and get closer and closer down to the left corner, bottom left corner. I do tailor ARVC athletes because the data, which is what the question was, is actually quite good, not just in mice, but in humans, that endurance training sports, long distance running, long distance rowing, long distance cycling, that kind of endurance training effect puts a stress on the right side of the heart pump. And that stress acts as a disease accelerator to the ARVC substrate. Now, admittedly, the data is strongest for just one ARVC genotype called PKP2, but that's the most common, more or less, of the ARVC root causes. So I can't support shared decision-making. Doesn't mean that Susan and I let you do whatever you want. That's not the definition of shared decision-making. So when the data is so good, I can't have an ARVC athlete come into my office and then have me have signed the forms for them to do the Boston Marathon. Because I know that I'm sending them to a disease accelerating activity, not just the Boston Marathon day, but all of the training to enable you to do Boston Marathon. So I try to throttle you down to a different style of sport. And if that means, hey, I'm a marathoner or nothing, well, then I guess you're going to be a nothing, because I can't endorse you being a marathoner. And so I try to get them to more static burst type sports, if you will, baseball, softball for females, and so forth. But there's sort of the blacklist of sports for ARVC, long distance running, cycling, rowing, swimming, long distance, that I simply can't support.
There were somewhat reassuring data that came out, probably a decade ago now, maybe not quite, from Cynthia James, I think, that recreational sports did not convey a signal for harm in ARVC, correct? So
Right.
getting, you don't have to be a couch potato with ARVC.
Exactly. But I think too that that's where it gets tricky, I think, and that's why I find myself unsatisfied with this and wanting to do more for the ARVC families. I would love it if we are able to figure out a way to attenuate the ARVC disease process in a way that allows a return to marathon running, if that were to be your, but we're nowhere close to being there yet.
Mhm. Thank you, Mike. And we have some more, if there are ARVC questions, we can include those tomorrow in our fireside chat when you're joined with Dr. Hari Tandri.
Yeah, looking forward to that.
Yeah, we have another 3 or 4 minutes here. And here's a comment. How often are guidelines updated for long QT1 in sports?
I don't know. Well, so the last official AHA ACC guidelines was 2015. It was touched upon again in 2017 with the Heart Rhythm Society Ventricular Arrhythmia Sports. There's going to be new disease management guidelines coming out for long QT probably in the next 6 to 12 months, led by Arthur Wilde. It's not going to be sports participation specific. So if I had to guess, I would guess maybe ACC AHA would do another update of their sports statement in, say, 2025. It's sort of been averaging every 10 years.
Okay, thank you. Let's see. Are there sports that my now 4-year-old may be able to play when older? He has CPVT and with precautions, of course.
Yeah, so CPVT, there are going to be more events in CPVT athletes than long QT athletes, no doubt about it, probably twice as many. We're at about 1% for long QT, we're at about 2% for CPVT. But I think an athlete with CPVT, he or she can almost do anything that he or she loves. It may be ultimately going to triple therapy to have that CPVT person as protected as what we would want, meaning triple therapy as in UNO, beta blocker, dose, flecainide, beta blocker nadolol, dose flecainide, and trace, the left cardiac sympathetic denervation as the trifecta package. But our athletes with CPVT, they currently range from little leaguers to professional athletes. So my view for that 4-year-old is you should not make your 4-year-old an athlete because of this safety signal. You should let your little 4-year-old just discover who he or she is and what they love. And if despite your best efforts to give them a crochet needle, they always are throwing the football or throwing the softball, then don't worry or fear that, because I think sports and CPVT can safely coexist. I just want as a parent of a 4-year-old say, aha, now I'm going to engineer them to be my next professional athlete to take care of my future retirement needs.
I think I'd engineer them to be very compliant with their medications. I think medicine compliance and CPVT is really the key.
Really the key. And I think you're absolutely right. In fact, our only breakthrough events and unfortunately a recent breakthrough tragedy has been where they, in the 18 to 22-year-old bracket, chose to just stop their medicine for a handful of days, weeks, without informing anybody.
Okay, very good. I think we have more questions, but I think we'll hold some of those until the panel discussion with other presenters. So
Well,
we appreciate your time, Mike, today, and Susan.
thanks, Marcia. Thanks.